Weekly Checkup. We're brought to you by Georgia Urology. I'm your host, Dr. Bruce Feinberg, and we are live and in the studio taking your calls at 404-872-0750. You know, it's fascinating when you think about what are the 10 top reasons, kind of the David Letterman top 10 list, 10 top reasons that people go to the doctor. And you might not be surprised. You might be surprised at what's on the list, but it wouldn't be surprised at number one because it's back pain. And it's been back pain now for multiple decades. Coming in as a close second is any symptoms of flu or cold. But back pain continues to be the number one complaint in America. And even though we've kind of changed our work profile, and we're not necessarily doing nearly as much manual labor as we were 50 years ago, back pain still remains a top complaint. And there are many, many reasons for that. We're going to get into those reasons why back pain is a top complaint. Understand when do you need a specialist? What are some of the new procedures and treatments that are available to treat back pain? How do you know when to seek that specialist? What are those options? And have you even thought about possibly getting treatment overseas because of cost, as healthcare costs continue to loom large in both the media as well as in your pocketbook issues? So we've got a lot to talk about today as we focus on back pain. And we're going to do that by having in the studio live with us one of Atlanta's leading experts in the field of back pain, Dr. James Chappuis. Thank you. There's a spelling issue there. So James Chappuis of Spine Center Atlanta. We're going to cover chronic neck and back pain, sports industry, surgical options, rehab, and some even the patent surgical products that he's responsible for. Again, join the conversation. Give us a call, 404-872-0750. Now, Dr. Chappuis is founder and lead surgeon and CEO of Spine Center Atlanta. He is a clinical instructor with Georgia Regents University, formerly the Medical College of Georgia, and has staff privileges at Emory University Hospital Midtown. He is a published author, frequent principal investigator for clinical trials, the owner of several patents for surgical products, and one of the country's 207 spine surgeons and specialists to know, according to Becker's Orthopedics. You can learn more about him and the practice at SpineCenterAtlanta.com. So great to have you on the show.
Thank you.
And it's a topic that we've covered before, but I'm not sure there's ever too many times to cover it, given the fact that it is the number one complaint still today in America. And I guess because such a common complaint, we tend to think of those common complaints being the things that people take to their primary care doctors. And I guess one of the biggest concerns often is, and especially in as we deal with these issues in medicine today, in the cost side of medicine, there's the notion that specialists are more expensive and you're supposed to start with primary care. But because much of back pain becomes chronic, how does a patient know when to seek out a specialist?
Well, it's a good question, Bruce. I think primary care doctors are always a good place to start with back pain. I think probably the time I would think would be most likely for someone or patient to seek a specialist would be if they have associated leg pain, numbness, weakness. I think that would probably warrant an immediate consult with a specialist. Any bowel or bladder issues, numbness in that area, difficulty urinating, things of that nature, I think probably that patient should seek a specialist primarily.
And that would be immediately, because now we're talking about potential for nerve compression.
That's correct. Either seek a specialist immediately or emergency room for that problem.
Okay. Now, and for the patient who has had some kind of chronic back pain, has been started with primary care, are there triggers that would say, you've been doing this long enough, you've tried this, you failed that maybe it's time to request a referral to a specialist?
Yes. I think if you've gone 3 months with your primary care doctor, you're not improving, your symptoms are worsening, I think it's time then to ask for a consult to a specialist, because obviously the care that you've been getting isn't solving your problem.
So I think one of the things that's also confusing when you seek a specialist, especially for back pain, is who manages back pain. So we've got physical therapy clinics, which sometimes would have physicians called physiatrists and sometimes just physical therapists. You've got orthopedists. You've got neurosurgeons who focus on spine. I think it's so much of our system that's fragmentation makes it really confusing to consumers. I don't even know who to go see, and should I, and to what extent, as we try to get the consumer more educated, so that they can participate in their own decisions and not just go where they're told, but actually to be able to invest themselves in that process of getting that specialist, how do they know who to go see?
Well, that's a good question. I guess being an orthopedic surgeon, I would say that probably an orthopedic surgeon is the place to start. But
It's good you have no bias in this at all.
but definitely biased there. But I think anyone who's really trained in treating back pain conditions, hopefully they're board certified. But I would say orthopedic surgeons, neurosurgeons, physiatrists, or sort of non-operative doctors that have a wealth of knowledge related to back pain. So I think those three physicians for sure are someone you could start with, and then they can certainly make appropriate referrals to other specialists such as physical therapists and things like that.
All right. So in your practice, I'm curious, what % of your patients are coming from physician referral versus patient referral as we talk about all this healthcare stuff and how it's changing and whether patients are truly getting more invested? And has that referral pattern changed over the last decade?
That's an interesting question. It has changed. I would say probably 20 to 30% of referrals now are from physicians, and a great percentage now are coming directly from the internet, from patients doing Google searches, liking what they've read on our website. So I think there's more and more patient involvement with choosing their physicians than there was 15 years ago.
So 20, 30 coming from referring physicians. What was it 10 years ago?
40, 50, 60, 70%
Really?
were coming from referred. Of course, the other problem has been now with healthcare insurance changes, so many patients now are told you can't see this doctor, you can't see that doctor. So I think the old way of referring through networks has been compromised a bit because of the way insurances have changed. So and I think patients are much more informed today than they've ever been.
So you obviously have spent time now focusing on your website. It's kind of a funny thing for physicians that, there are things that just didn't dawn on them. I mean, their focus was all clinical training and being the best they could be at their profession. And they can't do that anymore. They've got to have this expanded focus.
Definitely, especially in a big town or big city like Atlanta. Maybe in smaller cities, that's not as necessary. But there's a number of people, patients who move to Atlanta that really don't know where to go, who to see. So I think they do like many of us do. They do some sort of a search, Google search, get on a search engine and look up a physician that treats the problem that they have. So I think if we're going to be good physicians, we need to tell patients who we are, what we do, what our credentials are, so patients can make an informed decision.
Yeah, it's interesting because I would say probably a decade ago, and even less, and for many, it was kind of anathema that somehow I don't market. That's it's kind of it dirties me. I don't want to. That's not what physicians do. But I would agree with you that it's difficult today, and in a way, it also is part of that changed attitude that it's not so much patients are coming to doctors say it's not your problem. Let me take care of it.
Yes,
we're telling patients we need to work together because there's things that you can do for yourself, which gets into all kinds of issues about prevention as a question that I want to get into at some point in the show. But, it's all that greater responsibility and ownership, and probably more in an area like back pain, where there are a lot of things patients can do for themselves in terms of even the way they're going to manage themselves if they need weight loss, the way they're going to approach rehab, whether they're surgery or non-surgery. So I think that patient engagement piece is a critical piece of this, which is very much changing in the way we practice.
Yes, absolutely.
Now, another piece that's changing a lot is where we manage patients. Because again, 10, 20 years ago, everything was done in a hospital. But
yes.
Today, in many practices, almost nothing's done in the hospital.
Yes.
So you're where on that spectrum?
Well, we have a comprehensive spine care program at Spine Center Atlanta. We have physical therapy, rehab, we have a surgery center, we have an MRI center. So we really have a complete program except inpatient surgery. So what's happening, at least in spine surgery, a number of these procedures now are more minimally invasive and can be done as outpatient procedures. And from my experience, most patients would rather go home to their own home that evening if it's safe for them to do.
And what do you think percentage-wise today, if we took for every 100 patients who come to you with as a new patient with a back complaint, what % of them end up with a hospital-based procedure?
Well, first of all, probably of 100 patients we see, 20 to 30% would end up with surgery. The other 70, 80% would be conservatively treated.
Right.
Of the patients that are operated on, I'd probably say 60 to 70% of those patients now are treated outpatient.
Wow.
Where
So we're
almost,
talking like maybe 10% of the patients who would come to see you would end up with a hospital-based surgical procedure.
that's correct.
Yeah, because I don't think people get that. I don't think they get where, how we've evolved in our understanding of these diseases and manage these problems. And I don't know to what extent those are deterrents, that they're suffering and they think, well, I don't want to get the opinion because I don't want to go through that.
Yes.
Whatever that may be, and that often is, I don't want to be in the hospital. Hospitals scare me. So we're going to get into all that. We've got calls coming in. We're going to get into these questions about how you prevent back pain to start with. If you've got it, what are the things you can be doing for yourself? How do you select the doctor? What are the kinds of therapies, non-surgical and surgical, that are being used? Stay with us. Checkup. I'm your host, Dr. Bruce Feinberg. We're talking to Dr. James Chappuis of Spine Center Atlanta, and we're taking your calls, 404-872-0750. We'll go right to the phones to Paul in Doraville. Paul, how are you?
I'm good. How are you?
Good, thanks. So, Paul, this is a short segment. I want you to try to get me that question out in a minute.
Okay. I had a surgery twice, lumbar L4-5, and it's still having pain all the time, but last whole week it's been killing me for pain, especially in the morning when I get up from the bed. Do I need to can a chiropractor can help me, or I need to go see a doctor?
All right. So first, let me ask you, what's your age?
I'm 52.
You're 52. And when was your last surgery? How many years ago?
Last surgery I had in 90.
In 91?
Yeah.
So more than 20 years ago. And now
Right.
and so this new back pain is sudden onset?
It suddenly about last 5, 6 days ago.
All right. So I always often do this on the show. For those who listen, know I kind of played the internist. I was trained in internal medicine, then went on and became a cancer doctor and oncologist. And so for me, it's like the patient comes in, and I'm always trying to make the decision: should I send them to the specialist? So generally, anybody who's had prior surgery, they're getting to a specialist because it's already mucked it up enough that I'm out of my league as an internist. But the fact that you had 20 years ago, more than 20 years ago, surgery, and now you've got acute onset back pain. It definitely seems to me that something needs to be checked. Am I going the right direction?
Yes.
All right.
Yes.
So take it from there, Jim, as far as, kind of your first thoughts on this.
Well, certainly I think you need to see a physician. And at that point, a physical examination, whether x-rays are necessary, not sure, but certainly a physician, conservative care, maybe some medication. If it doesn't improve, then the next step would be to a specialist, probably an MRI scan to see if there might be another disc or a problem going on. But if you're leg pain, or if you have leg pain or weakness or numbness in your leg, then that would probably accelerate my thoughts about seeing a specialist.
Okay.
So,
Thank
Paul,
you
was the answer to any of those things affirmative? Do you have any problems with pain going down the leg?
No, I don't have a leg pain yet. Yeah. It's just right at the lower back with the left and right, both sides on the hip. It goes in the morning really bad, and slowly during the day it comes down again. But at the morning time, it's really pain. I have a very hard time to get up from the bed.
So you're talking about impact on your lifestyle, on your quality of life.
Yeah, it sure is.
All right. Yeah, I mean, those are also kind of, indicators that say you should do this sooner than later.
Okay.
All right. Thanks for your call, Paul.
Thank you very much, sir. Bye-bye.
Bye. All right. So this idea of somebody who's had problems before and problems again is not unusual.
No, it's not. It's really not. It's reoperations on patients who have previous spine surgery are high, and especially people that have had previous lumbar fusions.
And again, you were telling me before there's a name for this, right?
Failed back surgery syndrome.
Failed back surgery syndrome. So if you were at a conference and there would actually be like a segment of papers presented on failed back surgery syndrome.
Yes.
So this is the accepted way in which you all reference it. So it's pretty common.
Yes.
All right. When we come back, we'll be taking more calls, getting into more of the issues related to prevention as well as management of back pain. Stay with us. All right, Jim, I want to get back into this. And we were talking about kind of the complexity that is part of modern medicine. And we were talking about the fact that it's so hard to even know what kind of doctor to go see. And we didn't even get into the kind of, I'm not sure we call it the allied or alternative fields, but one of the big ones in back pain would be chiropractic.
Yes.
And I was trained as an osteopath, so I get it. But to me, there was that difference in my training that I had, the full 4 years in medical school, and I guess there is that certification difference. And so I'm curious, how you feel about it and how it impacts on, your practice.
Yeah, it's a great question, Bruce. I think there's a definite need for all sorts of specialists that treat back pain. And we don't have all the answers as medical doctors, and I think chiropractors offer a significant benefit to a number of patients. And in fact, in our practice, for probably 2 or 3 years, we had a chiropractor that worked with us. A number of patients were helped very much by her care. And I think the real key is we all need to work together as specialists, and that's what we enjoyed by having her work with us, is that we were able to work together as a team. So I think there's a definite place for chiropractic care, and I think they do help a lot of patients.
I'm hearing a but in there somewhere.
Well, the biggest issue, I think, is, and again, maybe as a medical doctor, I do think patients should be evaluated first by a medical doctor that's trained in musculoskeletal medicine. At that point in time, a patient can be referred to chiropractic care, and I think many times are helped by that. But I do think it's best to have an MD or a medical doctor, DO, who can evaluate the patient initially to make sure there aren't any red flags.
All right. So, and red flags would be what kind of things?
Red flags would be a fracture, a metastatic lesion, maybe symptoms that are suggestive of a cauda equina syndrome, which is a problem with bowel or bladder, a problem with compression of a nerve root. So those are all red flags that I would hope could be picked up by the medical specialist initially or ruled out, so then the patient could be referred for chiropractic care or physical therapy or whatever other conservative modality would be appropriate.
All right. And I would guess within all those situations, any kind of active manipulation would probably be contraindicated.
Yes, in my opinion, it would be. And again, I think those are the red flags that need to be and should be ruled out before a patient's sent to chiropractic, physical therapy, or any other conservative modality.
All right. So I don't want to leave that subject for good, but I do want to go ahead and take a call from Carolyn in Hampton. Carolyn, how are you?
I'm fine. Well, I'm not fine.
Well, you're not fine. You wouldn't be calling, right? So what can we do for you?
Well, I am seeing an orthopedic doctor, and I have spinal stenosis between L3 and L4 in my back. And I also have a protruding disc in that area also. Well, I've had my third epidural shot this year. I've had this back pain for 4 years. I've had shots, not all 3 in 1 year, but this year I have had 3 already. And I had a spell about 2 weeks ago where I was walking and all of a sudden I couldn't walk. I couldn't use my right leg. I couldn't put it down on the floor. And until I got some pain medicine, I couldn't do anything. So that was when I had my third epidural shot. So I'd like to know, is there anything, any other procedure that you think I could have other than surgery, and if surgery is my last resort?
Do you have leg pain also?
No, I do not.
It's all back pain.
It's more in my hip. I mean, it's low. It's way low, and it's been all back pain. I've never had a pain shooting down my leg. Now, I don't know that there was a pain shooting down my leg. I just know I couldn't put my foot down on the floor to walk.
When's the last time you had an MRI scan of your back?
2 weeks ago.
Okay. At this point, if it's primarily back pain and the epidural blocks aren't working, there are other injections that can be done to your facet joints, and then something called radiofrequency, which can help a lot with the back pain. Mm-hmm. If that fails, then surgery could be indicated, and there's a number of minimally invasive procedures now that could help you.
Okay, and would that be done by an orthopedic surgeon or?
Orthopedic surgeon or a spine surgeon or a neurosurgeon that specializes in spine.
And so, Carolyn, do you know that your orthopedic surgeon does have a spine specialty practice, or because, again, orthopedics is a broad field?
Yeah. Well, I don't know. I know that he has been treating my spine. I assume he does. I don't know. he is the back doctor in this group of doctors.
Yeah, then I'm sure he's got the training for that, and I'm sure that's something he's thinking about. But that's what I would think about if you were our patient. I would consider now looking at your facet joints as a possible source for pain, and perhaps injecting your facet joints to see if there was relief of symptoms, and if so, then a procedure known as a radiofrequency, which is an outpatient injection procedure. And I think you might benefit from that.
Well, he did suggest that. I was actually to have these facet shots the week after I had this problem with my back and my leg. I was supposed to go. I was to let him know if I wanted to have that procedure done. And in the meantime, this other happened with my pain shooting down my leg. Do those facet injections not interfere, or it doesn't mess you up if you've already had the epidural?
No, it doesn't. They're very helpful for that. But if you now are having leg symptoms, did that come on after your MRI scan was done?
No, no. The MRI was done after I couldn't walk.
Yeah,
Right.
I think that seems to be where, Carolyn, if there's confusion about your care, it's whatever happened when you said you couldn't put any weight, you couldn't do weight bearing. Because that inability to do weight bearing, if it's strictly because of back pain, or is it because of weakness or any compromise to a nerve that supports the leg with weight bearing, trying to understand that in greater detail, I think, is what's causing some of the confusion, whether you have options, or because once a nerve becomes significantly compromised, you've got to relieve the pressure on that nerve.
That's right, Bruce. And another diagnostic test that could be helpful is known as an EMG nerve conduction study. That actually looks at the physiology or pathophysiology of the nerves going to that leg. And that could be another consideration. But it sounds like your orthopedic surgeon is on this, and it sounds like he's doing a good job. And I would definitely agree with him for consideration of the radio frequencies of your facet joints.
Okay, good. Well, thank you so much.
Carolyn, much appreciated.
Thank you. Bye-bye.
Bye. All right, so it's interesting because often with the calls, I always hope and pray that I got patients who know something.
Yeah, she's sharp.
And she was sharp. She really paid attention.
She was on it, and good questions.
And she asked good questions here, and she probably asked good questions to her physician.
And she had a good doctor. He was right on.
Yeah, no, and it was great to bring that out. All right, so I want to talk to somebody else. Let's talk to Lynn in Conyers. Hey, Lynn.
Hi.
What you got?
Well, I'm calling because I just have a problem with the motion, the mobility in my leg, which causes an unbalance, in my body. But I have no pain whatsoever. And I'm just wondering, what that could be. I have been to a neurologist, been seeing a chiropractor for, over 10 years.
So that certainly sounds effective.
I have an appointment to see a orthopedic surgeon in a couple of weeks just to see his take on it.
So with these different doctors, have they labeled what they believe is the root cause of this?
The chiropractor, he's the one who suggested I see an orthopedic surgeon because he feels like maybe there is a bulging of my discs that are hitting a nerve that's causing this issue. But, of course, he directed me to see an orthopedic surgeon on that to get that done.
And you made the reference to mobility, which we think of the ability to move the leg in normal range of motion. And is it the ability to move the leg, or is it pain when moving the leg, or weakness when you try to weight bear? Can you give us more detail about what is it in the way? How is that leg not being able to do its normal function?
Okay, for instance, like running up the stairs or running, period, I can't do it. And then in walking, if I'm walking down a hallway, I can do weight bearing on the leg, but my balance gets off because that leg is not moving right. It's not hitting right when I go down on it. So that's basically what I'm dealing with, and I'm just like, what in the world is this?
Yeah, well, I'm starting to get a little perplexed myself with the way you're describing it, but I got a nodding head in front of me from Jim. So do you think you know what's going on?
Well, I think her chiropractor made a good referral. I think it's time to see an orthopedic surgeon, and I think it's time for an evaluation, history, physical exam. Have you had MRI scans at all done yet?
I have. It's been a while. It's been maybe 5-6 years, and they did note that I did have a bulging disc in, I forgot which number it was. I think it was a lower, like right in the bottom part of my spine. They said that I did have a bulging disc. Of course, this was my general practitioner, and unfortunately, they didn't even go any further with reference on what I should do about it. And since I was walking fine at that time, I just let it go.
Right.
So,
well, I think it's good to have an orthopedic surgeon evaluate you, and it certainly could be related to your spine. And I think you're in the right You're heading in the right direction.
Okay. All right. That's good. Okay. Well, I do have an appointment with him, and I will carry forward with that.
I think you're on the right direction.
All right, so Lynn, next time we do a back show, I'm hoping you're listening and you call back in and let us know what happened. I'll be curious.
Oh, okay. I will definitely do that.
All right, great. Thanks for the call.
Thank you. Bye-bye.
Bye. All right, so I'm guessing that there are times when she's planning her foot where it's the weakness. It's got to be a weakness phenomenon.
That's what
right?
I would think. We didn't get a chance to ask her about EMGs, but
right, and what the neurologist did.
Yeah, I would imagine there's probably a nerve root compression. That disc has probably progressed. I would get another MRI scan. I bet it's progressed from what it was.
And that could happen where if she were in a gym and doing a leg press, she could press okay, but certain positions,
yes,
she is putting that pressure on the nerve, and it feels like the leg gives out.
That's correct. That's correct.
All right. So when we come back, we got more calls to go over. We're going to talk about what you can be doing to prevent back pain to start with,
yes,
as well as some of the non-surgical interventions of back pain. Stay with us. Weekly Checkup. We're brought to you by George Urology, and I'm Dr. Bruce Feinberg. We're live in the studio with James Chappuis of Spine Center Atlanta. And we're taking your calls, 448-720-0750. We'll go right to Greg in Atlanta. Greg, how are you?
Howdy, sir. Doing all right, actually, but I do have a pretty big problem with my my lower back.
All right, so Greg, let me interrupt you just 1 second. It's a short segment. Give me the question in under a minute.
I've got spinal stenosis, L4, L5, S1. Had a lot of injections, epidural, static joints. I had the nerve conduction study, nerve root burn. I have sciatica down my left leg, and basically been on pain medications. The only thing that's been able to help, actually. Sick and tired of it because I'm 28, and I was wondering, do you think surgery is the only option now?
All right, so I'm really curious. Before we get Jim to answer your question, it seems like such a young age for spinal stenosis.
Yeah, it was congenital.
Really?
Yeah.
All right. So Jim, with that.
Well, it sounds like you've had an excellent workup of conservative care. I'm sure you've had physical therapy along the way and things like that.
Yeah, I even did acupuncture to try to see, because I've had a lot of friends say that helped as well. Well,
you've had everything, and at this point, if you're still symptomatic, you would be a surgical candidate. And the basics, it can be done minimally invasive, but with spinal stenosis, you need decompression or taking pressure off the nerve root or spinal cord. And then at that point, the question is whether or not to do fusion, dynamic stabilization, or just the decompression alone.
Well, I had a myelogram done, and it said that I think at L4 it's 6 millimeters around when it should be 18, I think, in the caudal region. I'm not sure about that.
Yeah, that's tight. 6 millimeters is tight. Yeah, it should be 12 or 14. So you definitely have spinal stenosis. You would benefit from surgery. The question is whether or not you should fuse someone that's as young as you are. And there are other options now of dynamic stabilization. One example is a Coflex procedure that's done, and you would be an ideal candidate for decompression and dynamic stabilization.
So Greg, I'm curious, given that you've been dealing with this for a while, have you gotten a second opinion, or you're just working with the one physician?
Oh, I've gone to so many doctors around Atlanta. I've gone to surgeons. I've gone to pain specialists. I've gone to orthopedic people. I mean, the pain pills, for being so young, I don't want to. I don't want to be dependent on them for the rest of my life.
So has your I want to know about why you've been hesitant to get the surgery, but we're going to have to go to break. So if you can stick around, I'll talk to you after the top of the hour. I'd love to hear more and understand that thought process.
Yeah, of course.
All right, stay with us. Today we're live in the studio with Dr. James Chappuis of Spine Center Atlanta. We hope you're going to join the conversation, 404-872-0750. We're going right back to the phones. We're going to continue with Greg in Atlanta. So, Greg, let me update everybody on your situation. I won't do it justice, but I'll give them the essence of it. So Greg's a young guy, 28 years of age, with a congenital spinal stenosis. So he's got channels through which the nerves out of his back have to run that are much more narrow than they should be. And as a result of that, he's been struggling now for years with pain and has done every possible conservative measure. And the question is he at a point now where his only option is surgery? And why has he, to a certain extent, suffered for so long and not had surgery? So, Greg, I'm curious to hear from you to why you delayed it, if it really seems to be the only thing that's going to give you a real resolution.
Well, the biggest thing that I've struggled with is I know that stenosis is a natural occurrence just by calcium buildup and everything as you age. And a lot of the surgeons that I've talked to have said that as I get older, virgin backs, virgin spines are much more easy to work with than already cut into spines. And once you have a surgery, more than likely you're going to have another one and another one and another one. And also, I've got some reservations because unfortunately my mom actually had some problems with degenerative back syndrome and degenerative disc syndrome. And she actually had a lot of problems with a really bad doctor. Got a staph infection, and it just kind of cascaded down after that to where she actually overdosed on some almost overdosed on pain medication because she was in so much pain that wouldn't go away.
So I hear you, and these are all real things, but what we're trained in medicine is to use the evidence and not the anecdote as we make our decisions. And you've had these anecdotal experiences, with your family, and then you hear these things. And at some point, you've got to really try to be analytical and make your list on what is the probability of something going wrong with that procedure versus the suffering that you're having, and how much can you delay it, the way you're going, and what are going to be the complications of being on all this medication. Narcotics in a young man can be pretty disabling.
Yeah, I've been on. Unfortunately, I've been on every. The biggest problem is actually when I came down to Atlanta. I'm from Michigan. I came down to Atlanta where I saw a pretty not very good doctor where I was on a simple Schedule 3, Schedule 4 medication, and so he could bill my insurance. So I had to come see him every day. He put me on really two really strong Schedule 2 narcotics, and that really messed me up for a long time.
As I'm sure it would. So I want to bring Dr. Chappuis back in. So Jim and I were talking at break, and he may not go into all the detail that he was giving me since we were talking doc to doc, but for the audience, but kind of give them a flavor for kind of the things that can be done. And yes, there are pros and cons, but I think that you're going to have this at some point. You're a young guy and something's going to be done, or you're going to have so much compression in the nerves, not just will be a pain problem, but it'll be a function issue.
Yeah, that's correct. And if you could live with this pain without being on narcotics, great, I would live with it. But if you're having to take narcotics at this point, as a young man, you've failed all the other conservative care, and you have a condition that can be treated surgically, at least it's time to consider that and look at what your surgical options would be.
I've considered it. That's why I've gone to a couple surgeons. But the biggest thing they keep telling me is that, one, I'm going to probably have to have surgery again in 30 years. Two, it's not the percentage ratio of what they said to me is that's going to get better. Didn't seem worth it though I am on a pretty strong narcotic. I am. It's helped, and it's basically been helping me.
What percentage did they tell you would help?
The sciatica pain, they said more than likely 80. The actual back pain, I think they gave me like 50.
Well, I mean, the truth is the 80% is a conservative number, 80 to 90% success with surgical treatment of spinal stenosis. Now, if you have a fusion done, then I think you're certainly looking at more problems later. But if you just had the decompression alone or considered another option, such as a dynamic stabilization, that's an alternative for a younger person like you that I think could be reasonable.
Yeah, the only surgical procedure they ever told me was basically they need to cut my spinal cord. They need to cut my my discs open to relieve the pressure, and then then basically make the canal bigger. And
well, that's all true. Then the question is what to do after, and that's when the three options would be just to do that, do a fusion, which can be problematic later, or to consider one of the newer options of dynamic stabilization. And there's 3 or 4 in the literature to look at, but it's certainly something I would consider given
Jim,
your age.
Because we've got a lot of other calls we're going to have to get to. Give us just 1 minute on what is dynamic stabilization, and then we're going to let Gray go, and we're going to get to other calls.
Dynamic stabilization is just after the decompression's done, something that can internally stabilize the spine without the actual fusion type procedure. So that's dynamic stabilization. There's a number of these types of procedures available, but it's at least something I would consider at your age.
What would be the best for this kind of thing? What would probably be one of the best doctors for this for me to go see? Because I've seen a lot.
So Gray, let me just share with you. When you ask a doctor that, so a quick story I'll share with the audience is, so a colleague of mine had an in-law who was diagnosed with metastatic cancer to bone. And I got asked that question. And so, the uncomfortableness of that is you want to have humility and not say me. And then you're also thinking if he's not assuming it's me, it's kind of an insult in a way of, it's like, so what's he saying? You obviously couldn't be the right doctor, so there must be somebody else. And I think a lot of that becomes, there's lots of very well trained. So one, make sure they're certified, make sure they have a lot of experience with the procedure, make sure that they're someone who you can build a bond with of trust so that you're comfortable with them. I think you address those 3 issues, and there's probably not one person out there.
That's a good response. And I think the other question to ask is, does the surgeon do these types of procedures? Because if you're not doing it, you might not be for it. So whoever you're going to talk to about that, do they do those procedures? And how many have they done?
Okay, because my biggest thing is that...
So, Gray, I'm sorry, but I'm going to have to let you go because we got a lot of calls holding.
I appreciate it.
You're very welcome. You were a very, very good guest because you were very candid about a real difficult problem. Best of luck to you.
Thank you so much, Doctor.
Take care. All right, so I want to get to some more. Let's talk to Ralph in Cartersville.
Hi, guys. How you doing?
Great. How are you?
Good, good. So I've had 2 lower back surgeries. The first one, and I'm probably going to mispronounce this, was a discectomy.
Excellent.
And the second one was like 5 or 6 years later, and I got titanium cages. And that seemed to work pretty darn good because that was 15 years ago. My back's still feeling really well. But the doctor did say at some point in the future, I may have to have, it may affect the disc above it because I was L5S1. What kind of percentage do I see of having to have another back surgery?
All right, so I'm going to let Jim answer and give you the specifics, but for the rest of the audience, I want him at least to explain what titanium cages are to know this isn't an advance in hockey. All right.
That's
like
a good
a
point,
hollow
Bruce.
slotted bowl.
Yeah.
Titanium cages were developed in the mid-'90s for fusion, what's known as interbody fusion. They were put in place of where your disc was. They could be inserted from the back or posteriorly, or they could be inserted through your stomach anteriorly. But they were types of cages that were put in, so bone could be put in, you could develop a fusion. It worked very well. I used a number of those. It sounds like you've had a great result. Anytime there's a fusion, there's a risk later on, though, of developing what we call adjacent segment disease, which is basically problems at the level above or below, in your case above where your previous fusion was. The fact that you've got this much time is excellent, but sometime in your lifetime you may get to the point where you're going to require more surgery if your symptoms warrant it.
Yeah, I tell you what, I'm getting older. I don't want to go through that again. But
So, Ralph, how old are you?
I'm 56.
All right, but you still get in the car probably every day, even though there's a certain chance of your being, in an accident, and you probably, still go outside even when there's a risk of thunderstorms because you could get struck by lightning if you're not in the right place. You have no problem right now. So I would say, you've done great, and, God forbid you won't have to deal with it. If you do, you'll who knows what the science will be, will bring to us then.
Yeah, that's true. And I can tell you this, that my doctor told me it would be at least a year before everything was like set in stone back there, and it hurt almost for a year, but I can remember specifically one day getting up and kind of standing up on my feet and kind of moving my hips back and forth. And I said, hey, that feels pretty good. And I worked for one of the big, I worked for Lowe's for a long time, and I moved appliances around. And I was really scared about that, but my back's doing great. I don't work for them anymore, thank God. But
good, because this is a Home Depot town.
I only say that because I was moving heavy stuff all the time, not because I didn't like the company. It was a good one, but my back was great. But
all right, well, Ralph, we got to go. We're going to go to break, but you're like the poster child for, especially with that last caller, Greg, who was so worried about all the things that could go wrong, and you're the poster child for when it goes right. Thanks for call.
Yeah,
we appreciate it.
It went right. Thanks. Bye.
All right, everybody else, we'll be back. We're back on the Weekly Checkup. We're brought to you by George Urology. I'm Dr. Bruce Feinberg, and we're live in the studio today with Dr. James Chappuis of Spine Center Atlanta. We hope you're going to join the conversation, 404-872-0750, 404-872-0750. So it was kind of interesting in that last set of calls, Jim, how, we had a case of a 28-year-old guy with a congenital disorder, but most back pain is not going to happen in that kind of young person. Most back pain is really, I guess, part of diseases of aging and diseases of lifestyle. If I'm right, then you would think that prevention would have a lot to do with helping people avoid back pain problems.
Yeah, that's correct. And even early on, patients that are in good shape, good health, can prevent problems later on in their life. So I think the biggest issue for me would be keeping your weight down, not smoking, exercising on a regular basis, stretching before and after your aerobic type exercises. But even though that may prevent problems in your 20s and 30s, it's going to help you in your 50s and 60s.
All right, so I'm looking at you, and I'm guessing that you walk the walk as well as talk the talk. You look like you're in good shape, and so how do you manage? You got a busy practice. How do you manage? What do you do every day? How do you make it work?
Well, I used to always work out at the end of the day, and I'd get anxious. So about 5 or maybe 10 years ago now, I started working out in the mornings. So I do at least a 20 to 30-minute aerobic workout every morning, either running, jogging, treadmill, exercise bike. And I try to do some kind of weight training just a couple of times a week. But I think the key is to keep your workout to 30 or 40 minutes for me. If I do it much longer, I'm not going to be able to do it regularly. And I think the other key is watching your weight, watching what you eat. For me, it's minimizing carbohydrates.
So I think that people don't recognize, but when you work in medicine and you see that even if weight doesn't just necessarily get you into trouble by putting a lot more stress on your joints, and we can talk about that in terms of what actually, kind of how that translates, but it's really hard to rehab when you've had a procedure if you're out of shape and you're too heavy.
Absolutely. Everything is more difficult. The surgical procedure itself is more difficult. The complication rate's higher. The post-operative infection rate's higher. The post-operative rehabilitation is more complicated. So obesity makes back problems difficult from the conservative care all the way through the surgical procedure, should you need one.
And I'm guessing the smoking piece is because, again, risk the post-operative infection, especially pneumonia, as well as what it does to the vascular system and wound healing and other things that can become problematic.
Yes, and also there's a number of studies that show that it actually accelerates the degenerative process of the disc itself, makes it much more brittle and more subject to injury than patients who don't smoke.
That's interesting because I didn't realize that. There's so many things that smoking does. You don't necessarily think of it actually having that kind of a direct physiologic negative impact on bone and muscle tissue.
Yes, and we're not sure if it's related to the nicotinic acid itself or whether it's
Chronic
related
hypoxia
or hypoxemia.
Yeah,
but the disc is an avascular structure, so what little vascularity it has, smoking compromises it and increases your risk for degenerative disc disease later.
Wow. All right. So. Again, it's not like I'm sitting here talking to an obese doctor with a cigarette in his hand. You're in good shape, so you practice what you preach, and if you can do it with your schedule, there's no reason why people listening can't find that 30 minutes every day for themselves.
Yes, indeed.
Which I heard years and years ago from one of my mentors who was a cardiologist. All right, with that, we'll take a break. When we come back, we still have a ton more to talk about. We really haven't talked about how to make those decisions about whether you're going to do a non-surgical or surgical procedure on a patient, and what are those options. Stay with us. But I am live in the studio with Dr. James Chappuis of Spine Center Atlanta. I'm Dr. Bruce Feinberg. We're brought to you by George Urology, and this is the Weekly Checkup. We're taking your calls, 404-872-0750. We're going right back to the phones to Stan in Ackworth. Stan, how are you?
I'm doing just great, sir.
Excellent. What can we do for you?
Yes, my wife's at 70, only on Medicaid, spinal stenosis and degenerative, disease. And all they want to do is pop her full of, hydrocodones, Percocets. She's been as high as 10.6, I think. And nobody, they more or less threw their hands up. Is this something that would be available?
Well, I'm guessing before they started with narcotics or along with the narcotics to manage her pain problems, there were no other treatments. There was no physical therapy. There was nothing else that's been tried?
She's had physical therapy. She's had trigger point injections. She's had facet nerve blocks, epidurals.
And so was it any time surgery discussed?
Through one doctor that did the original surgery, L4 and L5.
And what surgery was that?
It was on the back on the L4 and L5.
But was it for spinal stenosis?
At the time, yes.
Yeah. So now she's got. And did she get any improvement from that surgery?
Very slightly, but now it's it's just complications afterwards.
Okay. And does she have any other health problems?
Yeah, COPD.
Is she on oxygen or not?
No, she quit smoking like 3 years ago. Drinking she quit 30 years ago.
All right. So, because, obviously with all kinds of complicated and risky things that are done, which could be things like a surgical procedure, you're always concerned about doing more harm than good. So you're talking about a woman who's already had a failed prior surgery and has all these other risk factors that could lead to complications like pneumonia and other things. So, she's not the easiest patient.
No.
So let me get Jim to weigh in though, but I wanted to weigh in that, if often happens as in my role, in my practice, that patients would come to me after they got a recommendation about a surgery or a procedure. And what do you think, doc? And I would say, well, here's how I would see it. And so those are the things that I would bring up that I think are real issues that even though the current solution may not be satisfactory, but it may be the safest because it may be something that doesn't have the best options.
Well, that's a good point, Bruce. I think the problem is if she's has a lot of medical problems, it could make it difficult for her to be safe to be cleared for surgery by an anesthesiologist. This would still be considered elective surgery. So if your wife has a number of medical conditions that would make her a risk for the operation, anesthesiologists may be concerned. Now, if she could be cleared for surgery, there are operations that could help her. For sure, she would need a decompression. And then the question is whether or not any fusion would be necessary. But for sure, I think, as Bruce mentioned, she needs to be cleared by her internist or primary care physician before even considering whether surgery would be indicated.
Okay.
So, Stan, while we got you on the phone, so I'm just curious, Jim, given all the issues that have existed for quite some time now around narcotic analgesics, other things like TENS units, are there other types of approaches that have proven to be of any benefit in order to reduce narcotic dependency in this situation?
Well, there are. TENS units are helpful. I think trigger point injections, as were mentioned. And then there's also an option of what's called a dorsal column stimulator, spinal cord stimulation. That procedure is done with a patient awake, and temporary trials can be done to see whether or not her symptoms could be relieved from an operation such as that. So that's another option to consider. But there are other options other than the surgical procedure itself, especially if there is a problem with her having general anesthesia.
So, Stan, lots to think about. We appreciate the call.
Yeah, she's had the stimulators.
She's tried the TENS units?
Yeah, and she, like I say, she's on Medicaid, so they really limit, what they will cover. What I was asking is if this is something that doctor can see her for possible something in the future.
Well, you can certainly call his office. I mean, that's and it's on the website, both for the Weekly Checkup as well as the station. Our guests are listed and their contact information.
All right.
All right, you take care,
sir.
Stan. Best of luck to your wife. So tough one, and we sometimes miss that. Our focus is always laser focused on the complaint, but there's a patient behind the complaint.
Yes.
And we were talking before about the obesity issues and the substance abuse issues, and the lack of physical training and poor performance status issues, and all those things they weigh pretty heavy in the decision of an elective procedure, which unless there's obviously urgent need to decompress a nerve, they have to be weighed in. Otherwise, you'd risk doing more harm than good.
There's no question. This was, for the majority of cases, it's an elective operation, and if a patient is not a good surgical risk, it's probably in their best interest to not have the procedure in case a complication were to come up. So I think you bring up a really good point. As surgeons, we always have to consider in an elective operation, is the patient a good surgical candidate from their medical standpoint?
And I think in this particular case, I'm guessing you talked before about that kind of 90% success rate in terms of relief of pain and spinal stenosis, but this is somebody who's failed a primary procedure. So I'm guessing those numbers are not as robust when you get into second procedures.
That's correct. The success rate drops, and especially someone of her age, her medical condition, you may not be, if you did operate, you may not be inclined to do as elaborate a procedure as you may want to do as a surgeon because of the risk that's imposed by her medical condition. So her results wouldn't be as good as someone who was younger, healthier, and didn't have medical conditions that could be contraindicated for anesthesia.
All right, so we've had a ton of calls today, which has been fabulous. We've covered a lot because of it. But sometimes for clarity, I love to kind of start to kind of think about the broad topics we've covered and put some structure around them. So when we talk about that patient with back pain who's either being referred to you or has sought you out as a direct referral, kind of give me what's that first approach? And what are the kinds of options that are likely there? Kind of if scenario A, they don't have need for something urgent, and then, which is probably the more common in the scenario B, something urgent.
That's a good question. The first thing we would do is evaluate the patient. History, physical exam, x-rays. If they've had any previous studies, imaging studies, we'd review those. And always our initial approach is conservative. And the nice thing about our practice is we have pretty much every conservative option open to patients, including aquatherapy, physical therapy. We even have massage therapy and an acupuncturist. So if a patient doesn't have an absolute indication for surgery, then we would offer them the conservative options. Hopefully they'll get better, and 80% of patients do without surgery.
So about 80% of people coming in the door end up not needing surgery because they will improve with those conservative options.
That's correct.
All right. So the 20% for whom those options don't work, I guess either they fail or the problem is recurrent. They get some relief, but it's not sustained relief. Then what are those kinds of surgical procedures that are going to be done for them?
Well, if we're talking about the lumbar spine, I think the first question would be, can you live with your pain? Because, again, it's an elective operation. You've had all the conservative care with anti-inflammatory medicines, occasional pain medication. Can you live with your symptoms? If you can, then I wouldn't recommend an operation. But if the patient's symptoms are problematic to where it's affecting their ability to work, it's affecting their activities of daily living, affecting their ability to function in their family, then it's time to consider surgery. And it depends on what the condition is, but today a number of us are doing more minimally invasive procedures that can be done as an outpatient, so it takes the risk down significantly. In the cervical spine, the same thing. We treat patients conservatively, but should surgery be indicated, there's a number of more minimally invasive procedures that are open to patients today that weren't really here 15 years ago. So I think spine surgery, all surgeries evolve, but spine surgeries evolve significantly today.
All right, so we say minimally invasive. I don't know if people, because we got laparoscopic stuff and robotic stuff and percutaneous stuff, and I don't know if listeners really get what that means. Is there still a knife involved, or there's no knife? There's just we puncture, we're doing things robotically. What does that mean? What is the nature when we talk about these minimally invasive?
Well, that's a good question. Any of those are possible. There's robotic spine surgery, although I don't think most of us do that. There's some that do, but I don't think in Atlanta, and I'm not sure it's the best option, but it is available. Percutaneous procedures are probably the biggest number of procedures that we offer today. Use of a microscope, I think a number of us are using. The use of percutaneous type procedures with fusions are available. So there's a number of procedures today that don't involve a big incision and that can be done as an outpatient to where you're going home the same day.
And we talk about using that microscope. You're actually looking through a microscope through some kind of portal or hole or incision in order to be able to magnify the field that you're working on, so you can better identify all these small structures?
That's correct, and also there's procedures done endoscopically, where a lighted device similar to an arthroscope is placed into the spinal canal. Surgery is done that way. So some type of magnification has to be, is necessary for these types of procedures, and they work very well.
And in the past, it would have been, I guess an in-hospital procedure with how many days of stay, and what would that difference in rehab and recovery be?
Well, a short time ago, 8-10 years ago, we would admit a patient for a major spinal procedure, and they may be in the hospital 7 to 10 days. The rehab afterwards was grueling. Post-operative pain significant. Now with the new procedures, a number of patients, as we mentioned, go home. We start rehab as soon as their wounds are healed. We have aquatherapy available in our office. A number of facilities in town offer that.
Now the aquatherapy idea is that because being in water, it reduces the amount of weight of the individual, so they're able to start mobilizing without having their full weight against gravity.
That's correct. So as soon as their wound's healed, we get patients out of the bed, into the water, start their therapy because the gravity is eliminated. So it's easier to do rehab in an early post-operative situation.
And I guess we've learned with hips and with knees, the sooner you get them moving, then not only is there lesser pain and greater, quicker functionality, but much less complication rate.
That's right. And it gets patients back to what they want to do quicker.
Fabulous. All right, we're still coming back for a little bit more. Stick around. My thanks today to Dr. James Chappuis of Atlanta, James at Spine Center Atlanta, for being live in the studio and taking your calls. Really a great show from the standpoint, lots and lots of interaction with the callers. And really, they were great in getting us to cover almost all the topics. We didn't have to do that much of the work on our own, which is always when we know we've hit a topic that's really resonating. All right, so for those who've been listening who are interested in talking to you about their own problem, how do they get in touch with you?
Well, you can reach us through our office phone. We have a website, SpineCenterAtlanta.com. I know we are on social media. Our practice is we can be reached through social media. But any of those sources, we can be reached.
All right. Now, we were talking a little bit over the course of the show that you kind of see your practice a little bit differently in terms of the resources that you wanted to bring under one roof.
That's correct, Bruce. Back pain doesn't just have one answer. So we like to offer all alternatives, and that was my goal in developing Spine Center Atlanta. We also offer alternative options, including massage therapy. We even have an acupuncturist. So under one roof, you can get high-tech, minimally invasive spine surgery, or you can get massage and acupuncture. And we also have a physiatrist, pain specialist, Dr. Chirikapalli, who can do minimally invasive injections. So I think for patients with back problems, this is the way to practice, and that's why we developed the practice as we did.
So you were telling me a little anecdote about your acupuncturist, and I thought it'd be fun to share it.
We have an acupuncturist, Mr. Wang, and I had a patient who I'd recommended.
Now, to be fair to Mr. Wang, he was a doctor in China.
He was a doctor in China.
He's not licensed here.
That's correct, but he does a trained acupuncturist. So I had a patient who I'd recommended cervical spine surgery. She'd failed at all forms of conservative treatment for over 3 years. She asked, is there anything else that could be done? I said, well, we got an acupuncturist. I referred her to Mr. Wang, and it's been 3 years. I haven't seen her back. She continues to see Mr. Wang. So he's taught me a lot.
Great story to finish on. Absolute pleasure having you on the show. I'm Dr. Bruce Feinberg. This has been the Weekly Checkup. Be well.